Hello, everyone. Thank you so much for being here, taking the time to join our webinar today. My name is Eric Lee, and I'm going to be the moderator for today's webinar. I'd like to welcome you all to the webinar. It's going to be on closed chamber horizontal sinus elevation. And so this webinar will introduce you to the closed chamber hydrostatic approach that transforms sinus elevation into a more controlled and predictable procedure. You'll be able to learn a bit about how this technique can provide more uniform membrane elevation, reduce reliance on lateral sinus surgery, and improve confidence and consistency in your everyday implant practice. And I also wanted to note that you will all be receiving 1 CE credit. In order to receive the credit, though, you must be active during the entire session, and at the end of the webinar, you'll also be receiving an email from GDIA with a survey. And once you fill out the survey, you can expect to receive your CE certificate by email within 14 business days. So as shown on the screen, there's going to be a question box in the panel board. Please feel free to ask questions throughout the lecture, and Dr. Lee will address them in the Q&A session after the lecture is concluded. And without further ado, it's my honor to introduce our speaker for today's webinar, Dr. Kwan Lee. He is a board-certified implant dentist by the American Board of Oral Implantology, the ABOI, which requires rigorous testing and case defenses. This board certification symbolizes the highest level of competency in implant dentistry. There are only 7 board-certified dentists in Washington and 400 in the US as of 2016, and Dr. Lee is among one of them. After attaining his bachelor's degree in biochemistry from UCLA, Dr. Lee went on to earn his dental degree from the University of Southern California, and since then, Dr. Lee has completed a year of implant training, general oral surgery training at the University of Washington School of Dentistry. And with that, I ask that you give your attention to Dr. Lee as he begins his presentation.
Well, first, I wanted to thank you everyone for joining me today. I know it's not easy to join the webinar like today's, especially after a full day of the work. Everyone is ready to go home, and yet you guys make a decision, stay extra time longer, and listen to, I guess, boring lectures, boring stuff. But anyway, my goal is to give you something to you guys, everyone can walk away or take home, so that you guys go back to your office, then you guys can apply this knowledge and the techniques that I've kind of shared through this webinar. I know we only have like 1 hour, so I don't think it's gonna be enough formats for me to share everything little detail, because anything about the minimally invasive is everything about very small detail. So I'm hoping that it'll give you some idea, and hopefully maybe you can reconvene later time so that we can kind of discuss and talk about. And I think this technique will immensely benefit you, because I will go over the cases from today, but patients will love you once you master these techniques, and you are no longer in blind zone anyway. So anyway, today's my lecture is about closed chamber sinus elevations. I guess the title is a little long, but anyway, to make it short and easy to say, I usually say CCSE, closed chamber sinus elevations in phlegm. Eric gave me a really nice, good background, but since I put my background on my slide, and let me kind of briefly review, introduce myself on my little bit of my bio. So my name is Dr. Kwan Lee, and I've been practicing implant dentistry about 20 years in Seattle, Washington. And currently I'm the board certified member for the ABOI, as well as the ICOI at this time, and also the American Dental Society Anesthesiology. One of those, the highlight of my implants or my dental career high is 2011. I won the first the tabletop clinical competitions. And this was a little bit of a memory and then meaningful because Dr. Karmish was the chairing this competitions. I hope everyone kind of knows him. He authors many implant textbooks. Now they are considered to be like a Bibles, fundamentals of the implant dentistry. Since then, I've been working as the podium speaker for with many different implant company. And lastly, I mean, one of my cases just got published last year in the Journal of the International Journal of the Future of Dentistry. So this is a briefly my background. So your times are valuable. So let's dive into the case today. Before I wanted to go into the case, I wanted to thank you, share this photo. I've been teaching and involving many years at the GDIA Global Dental Implant Academy. And we go down to the Mexico and we do a lot of hands-on live patient implant training. I get to meet a lot of doctors, and many of the doctors, pays good amount of money to do their procedure. Normally, that procedure that is not available at their private practice. When I met this doctor, her name is Dr. Techa, and then Dr. Nguyen. And then when she was assigned to my group, the first thing that she was telling me is, Doc, I don't want to do the lateral sinus approach because it's too much for me. I mean, it's kind of funny and weird. It was kind of shock. All the doctors came to the Mexico and to do a lot of the surgical procedure, including lateral sinus augmentation. But she doesn't want to do that. She said, it's too much. I don't want to do it. I just can't do it. So in my positions, I don't know how to teach her. I mean, someone doesn't want to do it, then I don't know. So this kind of made me think about, wow, there are some populations, good amount of the proportions who are practicing dentists who doesn't want to do the lateral sinus approach, who prefer the less invasive approach for the sinus augmentation. So since then, I've been doing this technique about close to about 3 to 4 years. Then it made me think about maybe I should compile my cases and then my the know-how and then real detail to teach or share with my technique with the other doctors. Then they can go home or their practice and they can serve their patients immensely. So I'm hoping the same thing happening to you as well today. So let's start today's lectures. So when we are talking about the maxillary posterior implant case, for instance, like this case here, you and I'm hoping that everyone's kind of know that when you're talking about the posterior maxillary teeth around the area, most of the time we are running into the sinus. I'm sure that this study kind of resonates my feeling as well too. Yeah, most of the time, probably 30 to 40 and even half of times somehow it involved the sinus. It just a matter of how much involved in the degree as well, for that one. So if you don't know, if you are shutting yourself from the sinus augmentations, that means you can't really do any half of the implant cases for maxillary arch, for that one. So sinus is one of those key components for you to build the implant practice, and plus the for your implant surgery for your technique, for that one. So that's how much frequently that we have to do it for sinus augmentations. So this is my photos of my lateral sinus. Yes, I mean, if someone asks me which method or approach do you prefer, then I usually, without hesitations, I usually say lateral sinus augmentations, because you can see the lateral sinus wall, and once you see it, you have a sense of control. You can cut through the lateral sinus wall and very carefully, and you can expose the Schneiderian membrane. Once the membrane is exposed, you can see the patients, they breathe in and out. you can see the membrane go up and down, up and down. Huge. I mean, that for me, that's very that's good excitement. It's a very, what do I say, sense of connectivity. I'm connected to the patients, for that one. So lateral sinus augmentation it's really rewarding, and then I think it's one of those the must the surgical procedure you will have to master, for that one. Once your membranes are nicely elevated, you can grafting inside the sinus chambers, depending on your choice, PRF, allograft, xenograft, whatever your cocktails of your graft materials over there. Once you kind of elevate those area, the outcomes are very, very stable. I mean, one of the benefit of this lateral sinus is, yes, it allows you to do some more stuff, such as troubleshooting. If you have a patient has a sinus pathology, then it allows you to remove. And if you have some sort of a sinus perforation during the procedure, it allows you to repair those perforations. So, but let's look at the facts. This study is telling is, because many times dentistry is somehow is following the medical field. Some things are popular in medical, then those ideas are transferred to dentistry, and then we now practice over there. Same thing, same concepts. I mean, this article is telling you, looking at the 2003 to 2018, basically they are looking at how much of what kind of surgery was done during the time, whether it was open surgery or whether it was done laparoscopic surgery, such as minimally invasive surgery. As you can see, the highlighted colostomy and many of those hernia repairs, appendectomies, and most of the time during the 15 years, over the 15 years, and the percentage of the minimally invasive the procedure, which is a laparoscopic approach, was increased from 38% to 93%. So basically, this article is telling us that the open surgery, yes, we are still doing it. Medical field, they are still doing it, but what the trends are, less invasive surgery is getting more popular. It's not because of someone's are driving, but it's because the patients recovers easy, so patient feedback is great, and doctors are more trained in those kind of minimum invasive surgery skill, so they are more comfortable and then predictable. So that's why it's getting more popular in medical. I'm sure, I believe that this same trend, the transitions, I mean, it's already happening or will be happening in the future. So I think that if you're doing sinus augmentations, if you're already doing the Crestal sinus augmentation, then maybe good. And my lecture will be kind of recalibrating and then introducing different ways of doing it, more aggressive case. But if you are doing the lateral sinus augmentations, then maybe this is a good invitation for you to transitioning out to the less invasive procedure, from now on. So let's look at the successful sinus augmentation. There are only two ways, lateral sinus and Crestal sinus. So I'm hopefully maybe the Crestal sinus getting more popular now or in the future. But the problem is things that I don't like it about the Crestal sinus approach. I'm sure everyone here, if you guys are registered this course and then listening to this the webinar, then there are always some sort of a pain points. Something's not working in your hand. Why? Or you never tried, so you want to find out what's new out there. Or if someone already have experience, then something's not happening. There's some pain that it's in your hand. So there are a couple of things that I didn't like it, Crestal sinus approach, before I was transitioning to the Crestal, for that one. Number one thing is blind techniques. Everyone knows that Crestal sinus augmentation is a completely blind technique. You can't see the membrane, and you don't feel the membrane at all. You're completely blind. And also, it's very technique sensitive because you're seeing YouTube, you're seeing some of the on-demand videos, and you're seeing the Instagrams and Facebooks. They show all the good cases. Hey, look at my Crestal sinus augmentation. It looks nice. And when that looks easy. Someone just make a tiny hole through the sinus chamber and then sticking the instruments, and then the membrane goes up, and then just adding some bone powder, for them. So yeah, it looks easy. So they go home and then they go to office and then they try, boom, right there. What's happening is, they have a perforations, and the membrane is not really easily that detached from the sinus chamber, and that doesn't go up that high, for them. So the technique sensitivity is one of those the things that I don't like about Crestal Sinus augmentations. The other thing is when anytime or every time someone says or something say minimally invasive or something minimum means it often translates to the minimum control. Yeah, because minimally invasive, we are making a small hole, tiny hole, and then through the tiny hole, we are controlling every moving parts. And sometimes that's not possible. So many times when you hear minimally invasive or minimum something, it means many times you have a minimum control. So those are the things that nutshells of the Crestal Sinus segmentations. When I'm looking at it, hey, I don't like it because it's not predictable. So I rather just do the lateral sinus and get it done and then just be done, for that one. So this is the pain points, the Crestal Sinus segmentations. So here's the Crestal Sinus segmentation. If I didn't cover any of the method or the approach that I over, then you let me know. I'd love to know. Many of this the Crestal Sinus segmentations techniques, I've tried it. And 1994, the osteotome techniques using the blunt instruments, we're using the mallet, and you're just kind of hammering the patient's sinus over there, you're breaking through. And it's good or bad because, yes, at the time, 1994, it was a huge paradigm change when you're comparing to the lateral sinus was the only options. But the problem is it created the vertigo. People, after you've done so elaborating surgery, the only thing the patient remember, oh, doc, yeah, you were hammering my head, for that one. So then that reduced the, all the meaningful of, the meanings of the surgery, for that one. So that's the osteotome techniques. And then since then, the Crestal Sinus approach techniques are evolved. Do you know why evolved? Meaning the first version is not perfect. So second version is not perfect. How about this? How about that? Just like a bleaching system. One single bleaching system is not perfect. So that's why so many different bleaching systems at the dentistry, and no single bleaching system is perfect. Same thing with the Crestal Sinus. They're using the osteotomes. They're using the bone area sinus for elevation. They're using the piezo balloons, and then rubber tips. Hydraulic, elevation. Piezo internal sinus from Dr. Sons, and then the latest one would be the Densaber technique from Dr. Huey. I think that's very popularized the Crestal Sinus segmentations, for that one. So these are the main streams of Crestal Sinus segmentation. But I've tried everything, and then yes, sometimes they work, but sometimes they've got limitations. Today's for the time, your times are valuable, so I'm not going to go over each technique's pros and cons because they are very readily available. AI, ChatGPT, then they will explain. But anyway, here's my thing. Whenever I was doing the Crestal Sinus segmentations, these questions are come back to me and hunting me. Number one core question is, how do you really know the membrane is intact when you're doing the Crestal approach? How do you know? How do I know? I don't know. The only time that I know is, okay, now I'm going to access the floor of the sinus. And then once I access the floor of the sinus, I'm going to push my instruments, and then I'm going to add in some little bit of the bone powder, and then I'm just going to take an x-ray, see how it goes. And many times you could try pinch the patient's nose and then have the patient, can you blow your nose? And then your air comes through the osteotomy, then boom, you know that the membrane has been perforated. So the only time that you find it out, the feedback is, something happened, membrane is already perforated, then you know it. Before that one, during the procedure, you have no idea. So that was one of my core questions. How do I know? Second question was, can I elevate the membrane 3 millimeters or more crestally? Look at the 3 millimeters, for that one. Anything Crestal sinus segmentation between 1 and 2 and up to 4, they are very, very predictable. You don't really have to worry about whether the perforation or not, because membrane itself has the ability to heal it over itself. So between 1 and 2 and 3, let's keep it safely 3 millimeters, for that one. Those are the low sinus membrane elevations anybody can do, and any of those conventional, the traditional, the Crestal Sinus the technique can deliver. But the problem is we want to go up higher, because residual bone height is 2 millimeters, and I wanted to deliver the implants, let's say 10. Then I have to elevate my membrane 8, the 8 millimeter high. But know that from your experiences, the more or the higher the membrane you are elevating, the more the chances are perforation. So that's the question. So how do I elevate the membrane more than recommended, the dimension, for that one. And the third question is consistency. Can you do it every time? For that one. I know the Crestal Sinus segmentation, the perforation rates most likely 20 to 30%, for that one. But I want something more predictable, something higher. I mean, if this method works one of my patients, but what about my 100 other my patients? That doesn't happen with your other patients, then I'm not gonna do it, because that's not a good thing, for now. So these are the core questions that I want you to think about it when you are looking at this sinus, the Crestal Sinus segmentation method. So so there is some theory behind of this one, but I'm gonna sum it up. My theory based on very easy these cartoon animations. Many times when you elevating the floor, there are two types of elevating floor. One, instrument mediated floor elevation. Looking at this left side, they are using the jackhammer to turning it, and by turning it, the instrument goes up, and then that way the floor has been elevated. But there the other method we are doing. We're making a small hole as well, same thing, but they're injecting some sort of hydrofluidic mediums, such as gel, saline, some sort of this kind of material, and then those kind of material goes inside a closed chamber, and then once it goes inside, it creates a pressure. Once it has a pressure buildups, then floor is kind of going up, for now. So the many times the conventional traditional the Crestal Sinus segmentation is the left side, the instrument mediated method. But today the technique that I'm going to go over is more likely indirect sinus augmentation, for now. So these are the very easy science, nutshell for today's. So this is the what I usually teach when people register my courses. So this is called closed chamber sinus elevations. So basically the theory is very simple. You make the same osteotomy, but instead of pushing the instruments, you are connecting proprietary tip, which is called aqua tips. And this tip it's cranked in, it's screwed, it's sealed inside the sinus, the osteotomy. Once that the aqua tip is sealed, then you create something I call Crestal seal, meaning that this area is watertight seal. Nothing goes out, nothing comes out of this, the Crestal seal. Once you create those, the closed chambers, then you have the real-time feedback, because anytime that the outside hydraulic pressure from the outside, it's going to be equal to the same inside closed chamber hydraulic pressure. So you have instant feedbacks and also instant the amount of how much of the membrane that you can elevate it, because depending on the amount of the saline you are injecting it, you can control the how much of the elevation you want it to. So this is very simple. I guess it's too simple. Well, there's more to it, but for today's time being, I think this is a way to explain to for that one. So let's dive to the actual case. Okay, so this is the case. I want you to immerse yourself. This is actually your patient over there. So this is a case, immediate implant case with the closed chamber sinus elevations. Patients comes to your office. She has a failing traditional breeze 13, 14, 15. And this is X-ray. And tooth number 13 already has a root canal, and then there's just some periapical abscess on tooth number 13. And this bridge is loose. So now we want to design your surgery. You know, you want to do your homework before you're doing any type of surgery here. So you got the CBCT. And once you get the CBCT and then you're looking at this sign, oh, okay, there's my extraction site. But I don't have that much of a residual bone height. Look at that. After the teeth are extracted, then I'm boom, right back to the sinus chamber. Sagittal view. So I don't have that much of the residual bone height here, not here. So when I'm looking at these types of the X-ray, CBCT, then probably I'm just gonna say, okay, you know, there's not much of the residual bone height. Let's do the lateral sinus approach, you know, for that one. So I mean, yes, we've been kind of autopilot, autopilot. You basically, hey, there's no bone, let's do the lateral sinus augmentation. But before you're looking at the teeth or the case, we also want you to look at the patients. So this patient is 55 years old. She doesn't have that much of the contributing medical history, but I've known her for 20 years. I've been seeing her many years. She has a really, really worse of TMJ pain, and her jaw locks very frequently. And then her post-op recovery is very much. Being a Korean, I mean, in my practice, I have a lot of the Asians and then Korean female patients. Many times we do a little bit of procedure, but at the end, sometimes they've got huge post-op, the complications such as bleeding, bruising, those, and pain and those kind of stuff. So she has a very limited mouth opening because of the TMJ issue. So now my surgical modality is changed, because before you got to do no matter what lateral sinus, but knowing the patients now, I have to think about, do I do lateral sinus? Do I do crestal sinus over there? So same question I'm going to ask you guys when you look at the patient, which method do I do it? So case planning is extracting number 13 and 15, closed chamber sinus elevations, and then bone grafting, PRF, medial implant placements, and then future, the prosthesis would be 13 to 14, 15, the implant bridges. So this is the photo of the extractions number 13 and 15. Once you get the initial extraction site, then you just kind of sound the extraction site, and using the special the drill and reamers. I'm going to show you the video later, for them, but this one is just photo right now. You access the sinus, the floor. Once you access the sinus floor, then you are going to seal this aqua tips. And one of those best thing about this aqua tip is, in my practice, I do a lot of immediate case, which means that my sinus floor or my implant side is not that flat. It's not edentulous hillside. It's always there's a slopes. There is a sockets. So this aqua tips can engage inside of the extraction site, the sockets, and then creating a crestal seal very, very very, very much, for that one. So I know most of the crestal sinus case comes out to the hillside of flat bone, crestal bone, but this is the only thing that by far that in my hand, that if it is immediate case, can you create the crestal seal? Can you access the sinus chambers without creating any kind of bubbles or any leaks over there? So that's once you the aqua tips install. Then once the closed chamber is established, then I'm using my the syringe, starting to detaching the initial sternite membrane. So first, couple of millimeters, you push and you pull, and you push and you pull. This is a real-time feedback. The membrane is not being perforated. Because if the membrane has been perforated, then when you're aspirating, you will get an air bubble comes from here. So now I don't even have to ask the patient, hey, can you pinch your nose and can you blow your can you blow your airs, for now. Also, sometimes, many times, if the sinus membranes are very thin, when you try those kind of Varsarma techniques, that air even make the perforation as well. So so I'm not even trying to do that, for now. So this one's, when I'm using my syringe, I already know that the membrane is intact, real time. So now, before we talk about the crestal sinus segmentation, it's complete blindness because you can see the membrane. You can tell the membrane. With these techniques, yes, you can feel the membrane. You can feel the pressure now. So once once the closed chambers are created, and then you're adding the saline, and then voila. So now, before, my sinus floor was very limited, about maybe 2 millimeters. So I have to do the lateral sinus case. If I have to do the lateral sinus case, because the lateral sinus case is only way, as far as I know, can elevate the Schneider membrane way up here, like 8 or 10 millimeter high up there. Crestally, you can try. If you are consistently successful, then I'm going to pick your brain and teach me. But crestally, that's not very, very unstable. But with this method, then look at this one. See how much very uniformly I was able to elevating the Schneider membrane. Once the membrane is way up there, then now no longer I'm bound by membrane. I can do the full drilling here, full drilling over there, because I'm not touching the membrane at all, from now on. So that's the closed chambers sinus elevations. Once the membrane is being elevated high up there, then I'm just do my drilling initial, same you guys are doing the under drilling. Then as my graft material, I'm using the PRF. Once the PRF is inserted, then I'm using the rest of the grafting material using these types of sticky bonds for that one. So then after this one, it's same thing, the routine primary closure over there. So here, PRF, bone grafting, you're covering around the area. And primary closures, and you're done. And this is a 2-week post-op. So the 0-day post-op, you will see the membrane ascending to way up there, like high up here. But eventually this membrane will settle down, and which is fine. There's no big problem, because as long as membranes is settling down and keeping them some space, like it could be tenting from the implants, or it could be some sort of a space over there. Once those spaces are well maintained, and then sinus is very well osteoinductive space, the new bones can be generated around the area. So that's your 2-week post-ops. And that's the same tooth, number 13, 2-week post-op, and then that's about 5 months post-op CBCT. As you can see, Schneider membranes are now, depleted, and then comes down, and then now they're covering this implant graft around the area. That's 5 months, and this is the about 2 weeks, and now that's about 5 months. As you can see, the patient didn't have much of the residual bone height. I think that the implant that I was placing in was about 12 millimeters the length. So considering the 12 millimeters, then I was able to get good amount of the crestal sinus augmentation, probably 8, maybe 10, something for now. So that's very stable, for now. So that's the one of those case what I can use this types of a method for that one. And by the way, if you have any questions, then there is a Q&A column. So so you can just post it. So I'll read it towards the end of it, then I'll try to answer it. So here's the thing. What's the significant about this case? Yes, no instrument-mediated indirect sinus graft. So now membranes, it's never been touched by any instrument. So there's no unsure thing. If my denser is gonna poking through the membrane, is my osteosomes gonna poking through the membrane, is the piezoelectric waters, the water jet's gonna be poking through the perforating to the membrane. There's nothing whatsoever. So we take the membrane factors for the perforation out of the equations, for now. So that's how the good about this techniques. Let's take a look at the second case over there. This is another case. This is a heel site. Basically, patient comes to my office, teeth number 14 being extracted. So patient wants the implants over there. And when you look at the CBCT, there's a bone, residual bone height. She does it, but maybe 2, 3, I'm guessing. And there's a little bit of the mucocele. There's a little bit about suicide, retention cyst over there, which is not a big issue. So now the first thing, everyone's do the same thing. They want to look at the residual bone height. There are the other factor which I'm going to go over my actual courses, but number one key component would be just like doing a root canal. When you're doing the root canal, you want to find out the working lengths. Same thing when you're doing the sinus elevations, you want to find out how much of the residual bone height you have it. So you want to CBCT tells about 2.48 about residual bone height. So what do you know about 2.4? Let's say round it down 2. Whenever you have a crestal, the residual bone height 2, then most of the crestal sinus augmentation, I do the lateral because the amount of the elevation is so much, the lateral sinus would be more predictable. That's true, which is true. Okay. But now, once I use these techniques, closed chamber sinus, sinus elevations, then do the same thing, crestal sinus, crestal incisions, full thickness reflected, and do the same thing, creating a closed seal chamber. So later I'm going to go over how to access the sinus floor without perforating, but you access the sinus floor and then hook it up those aqua tape and create a closed chamber environment. Once the closed chamber is established, then you are using this syringe. So as long as the bubbles in and out, then we are connected to the enclosed system inside our sinus. You got the bubble? Mm-hmm. Bubble up and down, up and down. Yep. So look at this syringe. So the bubbles, as long as bubble in and out, I'm pushing my saline and aspirating a little bit. Is the blood coming in and out here? So you see the blood comes in and out, comes out and goes back. That's where the blood goes back. So this is huge feedback because now I have a real-time feedback from the sinus. Now I have a real-time feedback, membrane is intact. Now I have a real-time feedback, the membrane is being elevated. So that's how much the control that we have it. Before the conventional sinus augmentation, you just make a tiny hole osteotomy and push the bone, like half cc, 1 cc, and then you just take the faith, and this is going to be elevating how much we have no idea. But this with this techniques, I have a calculated amount of the saline, the hydraulics, so that way I can calculate how much I can elevate the membrane, striatal membrane here. So this is the 2 weeks post-op. Of course, patient was IV sedated, so we couldn't take the same day the CT scan. So patient comes back 2 weeks later. Then this is how much of the membranes being elevated. As you can see, those membranes are more like a cloud because they are starting to coming down. Before it was, I'm sure that it was uniformly flat, horizontal membrane elevation. But once over the time, membrane starting to slowly descending it out, which is we want that because this membrane will come down. It's gonna create the apical pressure on the graft material that we are putting it in. So the graft material, it's not floating, it's not floating around or migrating around any of the sinus area. So the membrane, it comes down slowly, and then it's going to be tented, and then it will contain those graft material that I'm putting in. So this is the 2-week post-op sagittal CBCT. So as you look at it, the 17 millimeters. Okay. So if you have experience with the sinus augmentation, laterally, crestally, when was the last time you were able to elevate the membrane 17 millimeter high up there? I mean, that's only possible through the lateral sinus augmentation, not through the crestally. You can. If you know anybody doing this, then let me know. I'd love to. Maybe great minds think alike, but I haven't seen anything like that one. So 17 millimeters, the membrane up there. And about 5 months post-ops, like we expected, membrane descending it down, and then it stays up there. So we're gonna go over how do we make the membrane staying up there. It depending on the graft material that I'm putting it in, which I'm going to discuss a little more detail in our actual courses. But by making a cocktail graft material, you can make the membrane stay up there more. And this is about sagittal view from the implants. So now about elevation about 7.5 of elevations, sinus the augmentation. So before, my residual bone height was 2, and I was able to elevate the membrane about 17 millimeter high up there. And over the time, membrane will descending it, and then they settling down, finalize it for the 7 to 8 millimeters of membranation over there, which is good. So this is the before and then 1 year follow-up. As you can see, how do I know the successful sinus augmentation? You can kind of see through the recorticalized bones around the area. So if something's like recorticalized bones around the sinus, then your sinus graft material is excellent. It's not just a bone filler, but your body trying to converting to your bone to the actual the life, the ovum bones, for that one. So that's good things, for that. So that's one of those cases as well. So what are the takeaways? So PRF was used for so in this case, I only use the PRF as a sole graft material. So I don't know if you guys are comfortable with the PRF, that's good. If not, then this is a good time to opportunity to what is a PRF about. And during the courses, in my course, we do a little bit of touch bases of PRF as well. And then the mean bone gain after about 4 to 5 millimeters. And yeah, residual bone height is less than 5 millimeters. So basically, this is a good thing about PRF over there. So that's good. One of those good options for the graft material. Since we are getting close to 7, I know you guys want to go, hit the road and go back to your home, so let's talk about the final case over here. So now we talked about only the single cases, maybe single cases, some of the easy cases over there. So now we are the level up, for that. So can we do this closed chamber sinus segmentations for the multiple teeth? Can you do whole site? Can I move my membrane away from my implant trajectory? So can I do my drilling safe without worry about the perforating the membrane over there? So those are the good things, the question that we want to ask you, and then show this in this case over here. So let's look at this case. This case, patient comes into your office, tooth number 14 and 15, periodontally involved. Yes, there's not much thing going on. As you can see, sinus is very next close over there. What would you guys do this case? I mean, you can kind of post it on the Q&A things over there. If you have a different idea, then I'd love to share a different idea, because different idea makes it's all dynamic. It makes fun, for that one. So look at the pre-ops. So pre-op is 14th, residual bone height about 2.9. So interradicular bones about 3, probably a little bit shy from 3, about 2. And number 15 positions, yeah, a lot of bones are already gone. Residual bone height probably maybe 2.3. I mean less than 3. And this is the panel view. So now I have to look at this whole area. this whole the upper left lateral sinus for tooth number 14, tooth number 15. If you have to do it in this case crestally, then you will have to do multiple time. You do the 14 as a crestal augmentations, you do the 14 crestal augmentation, assuming that both of the crestal augmentation went successfully, and now residual bone height is about 2 millimeters, 3 millimeters. I'm delivering the implants 10 or something longer than that ones. Now I'm facing my challenging, the membrane elevation is about minimum 8 to 10 millimeter height. So what can I do? Yes, lateral sinus, it's a good tool. But like a Dr. Nguyen's, she doesn't want to do the lateral sinus. What can she do? Oh, she gonna refer to the other office? Yes, that's good. But as your private practitioners, sometimes that's not possible. So in this types of case, you wanted to take care of it based on the patients and then your techniques over here. So this is a perfect case for the lateral sinus. But my question is, can I managing it, this case, without doing lateral and doing crestally? So let's look at the surgical photo here. Initial extraction, super easy, periodontally already, the tooth is already out. It's already very easy extractions, atriummatically. And you pick one of those sites. I picked the number 14, the center interradicular bone site, as my initial osteotomy, the entrance to the sinus floor. And I'm connecting the aqua tips. So I'm now creating a closed system. So Crestal Seal is established and aqua tip is connected. Once the aqua tip is connected, then you're using your syringe and start detaching the cnidaria membrane. There's a little bit of a know-how, little detail I can show you later. You don't want to shooting the water initially, boom, you don't want to do that. So initially about 2 to 3 cc's of the water, salines, it's going to be used for the initial detachments. Once you do the initial detachments, you can feel the pressure is dropping. You can tell the pressure is dropping with your hands. Just like when you're giving injections, some of the area you push it and then there's a pressure in resisting your injections. Sometimes you go really easy, so same types of feedback, you get it. So again, same thing, once you do create the system, you have an instant, you have the real-time feedback, your membrane is intact. And now you are now elevating your membrane based on your calculations. So here, key things about Crestal Seal is a key factor. Now I have a real-time feedbacks. No Crestal Sinus segmentation will give you this real-time feedbacks. Hydraulic pressures, it's very important how you're doing initial push and pull. I know there's many doctors are very afraid of the first time, so they're not really pushing it, they're not really pulling it. Then it's not gonna create an initial the pressure buildups around the area. So there's a way we can do it, which I can teach you later. Then doing the membrane separations. So now my membrane is way up there, 18 millimeters. G. And I use a single site to elevate the whole chambers, just like a lateral sinus. When you do the lateral sinus, you make a lateral sinus window, and then using the window, you elevate the membrane together. Regardless from anterior borders, posterior border, you elevate the membrane together. With this closed chamber sinus techniques, you do the same thing. It basically, you're doing the lateral sinus approach through the crestally. So here, membranes goes all the way up there. And it's very important that sometimes the uniform elevation, it tells you how much you're committing, because some doctors, they're going little bit of a pressure and then little pullback, little bit of pressure, then their membrane elevation give you a little bit of wrinkly formations, but still elevated enough to do your surgery, but that kind of give you the confidence. So at the end, then since the membrane is way up there, so now I'm no longer afraid of perforating the membrane through my instruments. So I'm doing my full drilling for my implant placements. And again, this is my cocktail. Everyone has a different cocktail. Collagens, the PRF, Geno, Aloe, autogenous, everyone's cocktails over there. Later in the course, there's some bone graft cocktail that I'm recommending for the sinus, which we can go detail more. And you do something soft, PRF, Surgifoam, and there are different types of the graft material. You can control your directions where you're putting your graft materials for like this. I think this is I forgot the name, but anyway, I think it's one of those osteo something called, so you can control the direction of where you're putting the graft material. So now PRF is added. And the grafts, once the membrane is being, sinus membrane is augmented, then you just do the same thing, treat them as just like immediate implant placement. Place some implants. Remember, always under drill the osteotomy, so you get good negotiating the primary stability and grafting it. And then just to cover some PRF over there, and then do your ritual, close the primary closure. So now that's the post-op. So this is a 0-day post-op. As you can see, my CBCT measurements, initially it was 17, but as I'm doing the surgery, some of the salines kind of escape through the osteotomy, and then now it kind of shrinking down, descending it down to 10. But this is okay because because I'm done with all the implant at this time. So I don't really mind it whether the membrane comes down over there. So that's about the membrane elevated about 14 and 15, 12 to 10, 0-day. And then chronologically, you can compare. This is a day 0 post-op. This is the 0-day post-op here. You can see nicely membranes are elevated, Schneider. About 5 weeks later, you can see membrane descending it down. And I'm sorry, descending it down, but still you kept it about 10 millimeters of membrane elevations and about 6 months over there. And again, sometimes depending on the bone graft cocktail, if you want more radiopacity, then there's the way you can do it. But for me, I'm totally fine because this is only 6 months. Over the next 1 year or 2 years, this area will be turning into as the radio opacity, opacity, the sinus bonds, for now. Same thing, number 15, pre-op, 0-day, 5 weeks, 6 months. So this is about year post-op PA. I mean, I wish I can, get the crown photo, but many times patient, they don't have any pain, then they don't come back to the office, for them. So it's really hard to track it. But this patient has been on my ear. I mean, I was able to get the PA with those 14 and 15 implant cases, for now. So those are the things. So again, my thing is same results as a lateral sinus approach. So yes, can I handle it lateral sinus case? Minimum residual bone heights, and you have to elevate the Schneider membrane way up there in order for you to deliver the proper size of the implant. Then can I do it crestally? Many times, very unpredictable. I've been there, I tried it, and boom, one time perforations, air comes out. Then I have to switch my surgical setting to the lateral sinus, which is pain. for them. But once I'm doing this closed chamber sinus elevations, I'm not really running into the those kind of problem, for them. So now my proportions for sinus segmentation is lateral sinus about maybe 20%, and most of the 80% of my case will be was dealt with this closed chamber sinus segmentations. So I guess here's the thing. I want to kind of invite you to future courses. They've got 4 days, June 6th, June 14th, September 19th, October 17th. It's a 1 day. I mean, I guess 1 day it may not be enough, but I'm trying to my best, because I've got a lot of feedback from patients. I mean, not patient, from the doctors. Hey, can you do the more hands-ons and those kind of stuff over there? But now this year we've the structures 1 day, and it'll cover the a lot more detail. For instance, we're going to cover details about sinus, landmark, anatomy. Of course, if you're going to if you're going to the fight, then you're going to know your enemy first. So the sinus, the membrane, the anatomy, we will be in depth. We're going to cover. And also, my course, we're not blindly, hey, this is only my way or wrong way, or wrong way. No, I'm also touch basis regular traditional the Crestal Sinus approach. So we're going to cover in depth of how do I decide which one is a lateral sinus case, which one is a traditional, the Crestal Sinus case. If it is a lateral sinus case, then how can I convert the case to the Crestal approach as well too. And we're going to also cover some sinus pathology. Yes, I mean, in the presence of the sinus pathology, can I use these techniques? Yes or no? It's depending on how comfortable you are. So we're also going to cover those kind of how to manage it, those kind of situations. And we're also going to show you how to do the case when you have the membrane thickening. Membrane thickening, it's nothing non-pathological finding. You can just do without any problem. A lot of times our doctors are warning you, hey, don't do this, those will ruptures whatsoever. But actually, I do like a membrane thickening better, because the membranes are more resilient, so it takes a little bit more pressure, but they're less likely to perforate. So we can go over how to manage the membrane thickening case for the sinus, the Crestal. We're going to also cover some of the very key study based on the sinus, Crestal Sinus, and the article shows when and where the Crestal sinus augmentations or Crestal approach, the perforations are happening. So we can kind of prepare you. This is the most frequently the component or the parts of the Crestal sinus augmentation where you get the most of the perforation. So I can prepare you how to manage it, avoid those kind of problems. And I really like this ones between the bone volumes versus the sinus membrane elevation height. This is the key foundation for me to calculating if you're doing the conventional sinus augmentations, not the closed chamber, because closed chambers, I elevate the membrane way up high, so I don't even have to worry about. But if you're doing the conventional, the Crestal Sinus augmentations, how much of the bone that you're adding into, it's going to relate to how much of the membrane that you're going to elevate. And there's a ratio, when you go beyond that ratio, then there's a more likely of the perforation. So many times you see the Facebook, you see the nice dome shape right here. The bottoms are very tiny, and then like a mushroom, then the Crestal Sinus augmentations, the elevation heights are very high up here. Looks nice, it looks nice. Wow, that's good. But don't, sometimes just don't judge just by the covers. There's a lot of complication as well too. Delayed sinus perforations, those kind of stuff over there. This article will tell you how to design your membrane, the elevations. And also complication, of course, yes, how to manage the complications. No procedures, no techniques is complete without the complications. Although this closed chamber sinus elevations, the complication rate based on my my caseload is very low, probably less than 5%, for that one. But and yet there's a lot of different spectrums of doctors, because not every doctors are just like me. So I wanted to train you so that you guys can do the same, maintain very low levels of a complication rate for your surgical loads, for now. So we will cover those complication case materials we're gonna cover. And then one of those key thing is, now once the closed chamber is established, everything is very easy, very straightforward. But many times people fail it is this part, the entering to the sinus floor. Inside the sinus floor. So many times what breaks the case is the entering the sinus. And you are using the instrument to access the sinus. There's some way for me to teach you how to access the Crestal Sinus without perforating, very safely access the sinus floor as well. So there are some drilling methods that we're going to go over. So lastly, I want to share the doctor's case. So this is her case, Dr. Nguyen. She's the one that when I went to the GDIA Mexico, she said, I don't want to do the Crestal Sinus. I mean, I don't want to do the lateral sinus. And after the lectures, she took my course previously a couple of months ago. And she went home and she texted me, hey, Dr. Lee, I'm so happy. So this was her the second case. And as you can see, very nicely, this is a pre-op. I mean, she had a good amount of the residual bone height. You could do traditional sinus Crestal out here, but you can convert that traditional Crestal approach. You can practice it closed chamber. So she used a closed chamber, and then now you can look at this one. Look at the patterns of the membrane elevation, nicely well uniformed, elevated above. So now, once the membrane is elevated that high above, she doesn't have to worry about any more of the touching membrane perforation. She just carry out the regular surgery based on her usual skill. And this is her sagittal view. So the initial membrane was 5.29, the residual bone height. The implant apex about 3. As you can see, the membrane height is about 3 millimeters above. So I'm guessing she elevated about 6 millimeters of the sinus elevations with the Crestal. So it's good because, doctor who said, hey, I don't want to do this, I only want to do the Crestal. So now she can manage much more difficult cases. Otherwise, she would not handle this types of case, from now on. Another case with the Dr. Don Kim. He was also the doctor who attended my course. And again, he said, hey, docs, look at my case. I love those kind of case feedback. Go and take a picture and then just send it. And same thing, he used a very minimally invasive, minimum, I guess, yeah, I mean, just necessary the incisions, just Crestal incisions. And he hooked up the aqua tips and created the closed chamber sinus systems over there. And look at this membrane up there, way up here. Look at that. I mean, he didn't measure the distance, the height, so I don't know, probably 12 to 15. And look at this one, says W. Yeah. So these are the actual doctor's case. I mean, that's not mine, for that one. So they took the course, they took the 1 day and then didactics, lectures, hands-ons, and when they go back to their office, and this is the case they are delivering, for that one. So I'm sure that all of you guys can enjoy these types of the surgical the techniques. So no longer your sinus is not your stress, but it's more blessing, and it's good practice builder. You got a huge feedback from the patients because docs, I don't have any pain, those kind of stuff, for now. So now it's almost 7. So I guess, a lot of people, yes, they want to go home, for that one. So I'm going to look at some questions, see here. Okay. Okay, here's one question. So when you decide a letter or vertical 4 millimeter to 6 millimeter, okay, when do you decide over there? Okay. When do I decide? I think as long as there is with the closed chamber sinus membranes, I mean closed chamber sinus elevations, I no longer decide whether I do the letter or the crestally. As long as there's no open communications, there's just some residual bone height. If I can install the aquatives, then I can safely elevate the Schneiderian membrane. But if you are doing the conventional, traditional crestal sinus, then you will have to look at the residual bone height, and you have to plan out what kind of a implant you're gonna delivering. Let's say your existing residual bone height is 6 millimeters, and you wanna deliver the 9 millimeter implant length, then you only need to elevate 3 millimeters. 3 millimeters of the crestal sinus segmentation, anybody can do it. Versa techniques, osteotomy techniques, or you just drill it, adding some bone grafting in, and that will give you the 3 millimeters augmentation as well. So that's not a huge issue. But let's say you're doing the 6 millimeter residual bone height, whatever your reason, you are doing the trans implant, like a zygomatic whatsoever. You want to deliver like a 20 milliliters of the implant length, then you are trying to do crestally, then forget it. You can't do it that long from now on. So that depending on the implant length, and then depending on that'll decide how much of the elevation you're gonna need to. Next thing would be how would it be different if the sinus was perforated? So I have a video actual case that if the sinus membrane is perforated during this closed chamber elevation, then your water is gonna go through inside your sinus, and then when you're aspirating, you will suck out the airs. And patient, we can tell like this. Okay, so those are the things that also we have how to managing it for now. How much of the saline do you use it for placing 10 to 12 minutes? So that's really, really good questions. So how much do you use it? If you look at the average sinus chamber is 12 to 18 cc. So most of the time, the averaging it out, so sinus chamber is 15 cc. So my rule is you're using the 10 cc. There's a lot of other attending doctors questioning, hey, can I just use a 2 cc? Can I use a 3 cc? Yes, you could, but you don't get the pressure buildup that high. If you are using only 2 or 3 millimeters of the water, then it's basically same thing as the traditional crestal approach, same thing. So always I recommending to using a 10 cc. Then it'll give you a nice, good volumes for you to do push and pull, and you want it to feel the pressure feedback. But if you are only adding 1 millimeter or 1 cc of the liquid, then you don't get that pressure feedback right away. So the longer the amount, the liquid amount, the saline, the more the liquid, then you can feel the real-time feedback, the pressure. So that's what usually 10 cc. That's my recommendations. Okay, anything else here? Okay, healing cap placement on your surgery to prevent the accidental perforation, totally membrane coverage every case. Yes, it depending on what the primary stability that I get it. If I don't get that good amount of the good primary stability, then I'll just bury it. But if I negotiating good primary stability, then I just adding it healing caps on top of it. So that's kind of a pretty generic question, for now. Okay, so now time is 7:10. So I'm hoping that we'll see you sometime later. And then here's my informations. So if you have more questions and then a case sharing, then you can using my email. Then I usually reply back to your case pretty quickly. Okay.
Yes, and one last thing. Thank you so much, Dr. Lee, for sharing your knowledge with us today. Thank everyone for their full attention. Really hope you guys enjoyed the webinar and found great value during the session. please be informed. Dr. Lee already mentioned, but we do have hands-on sessions coming up soon in Portland, June 6th, Cypress, California, June 14th, Pleasanton, California, September 19th, and New Jersey, October 17th. So this is a great opportunity. We're going to be sending out flyers to your email, so you can check it out, register if you're interested. And please contact GDIA at info@gdia.com if you are interested, and we'll assist you through the registration process. And thank you guys so much. We really hope you have a great week.